Good afternoon and welcome to this last session in the EHiN 2016. I hope you all had a good time. It's hard to see you because there's a lot of light in our eyes. We're going to talk about patient empowerment, and that's why we actually do all this technology stuff that is for the patients. Or I don't really like the word patient, I like more the citizens, but you can talk more about that. My name is Nart Seurs, I work in ICT Norway, and I'll introduce our first speakers, also Cajander and Isabella Scandurra, is that right pronounced? They're going to talk about experience with access to health information, and, well, the floor is yours.
Yeah, now things are changing. So what we are going to talk about today is an e-health service that is up and running in Sweden today. And we have been studying this. We are a research team in Sweden from 6 different universities. Feels a little bit strange here, but from 6 universities, and I'm glad to introduce Åsa Cajander. She's the consortium coordinator for the DOME consortium, and DOME in our case stands for Deployment of Online Medical e-health Services. And I'm Isabella Scandurra, assistant professor, and Åsa is associate professor at Uppsala University. We have been doing these studies since 2012, and this is actually the date when, I should point up in your direction probably, the date when they launched this service for the first time in the region of Uppsala County Council. And as you can see, it was a sort of winter day, and it all seemed so good, and finally we would have this service, one of the world's first and one of the best services that would provide information from the healthcare systems to the patients. And then the question, everyone was so satisfied with being the first county council and one of the first nations to provide this service to the citizens or to the patients. But then, what happened? All of a sudden, there was a lot of questions about this service. So it says that this e-health service can be dangerous. It says that it could be a Lex-based scandal. You should actually stop the deployment and the use of this service. But there were also some positive voices, and mainly they came, of course, from the patient side, saying that it strengthens the power to the patients in care, and it's a democratic tool. Of course, you as a patient should have access to this e-health service. So this has been a very controversial question and controversial service in Sweden so far. And we as researchers, we have followed the deployment and the use of this service since 2012, and it's an ongoing work that we will talk about today. So this is our approach to the problem. The purpose of this consortium, of the researchers' work, is to provide and disseminate the knowledge that we build about adoption and use of healthcare records online, and also other e-health services if they come along and if they are attached to this journalen, as it's called in Swedish. And our aim is to benefit both the healthcare professionals and the healthcare organizations, as well as the patients. And we are working in 3 different teams with a number of studies that we have now both created and published results of, regarding patients and relatives, professionals and management, and also deployment and development studies. And a bit of a history. So we have in Sweden a national e-health strategy with an action plan. This is what you're about to accomplish within a certain amount of years. And in 2012, we were thinking, we in Sweden, that all citizens should have access to at least parts of their medical record during 2014. But this seemed to be a little bit too positive. It was a hard work, easy to say, hard to accomplish. So we changed it, saying at least all citizens should have access to their health record online by 2017. And now we're actually almost there. Now all but 5 county councils and regions in Sweden have access to all the patients have access to their proper record online. It is a political issue, so it's driven from the political side, which also has caused a lot of problems, concerns from the healthcare professional side. So this is what we will talk about, apart from how the service as such was launched. So what you see on the map here is a Swedish map of the 290 municipalities and the 21 regions. And the regions are the ones that are now connected to the national platform, and the platform as such will provide information to this service. We have a little problem though. All the lines you can see on the map are the borders between the municipalities and the regions, and all and every one of them is autonomous, which means there is a decentralized decision making within the regions, causing some problems if you would like to launch a national service. On the other hand, we have region-wide electronic health records. Compared to yours, as we have understood, in Norway, you have a lot of distributed systems where, for instance, primary care is not connected to the hospital care. But here in Sweden, we have 5 systems that are used. 5 of the big vendors in Sweden have the entire county council EHR, which is an advantage in this case. So we started with this work, and not us as researcher, but the county council in Uppsala started with the idea we should be able to provide the information to the citizens where they are, that is not in the hospital, and we should provide the information to them, and they should be able to look and take care of themselves via an augmented amount of information from the hospitals. That was the main idea. And it was a technical-driven question at that time in 1997. In 2002, Uppsala had a pilot with 500 patients connected to a service providing information for these patients at the general practitioner. So he and his patients were the first pilot in Uppsala. This use caused a lot of changes, and the service as such was actually stopped because it needed to get approval from each and every authority that you have alongside. So we have tested this system, we as Swedes, very many times, more than 20 I think, for each service or each functionality that was added. There has been a test whether this is possible to provide to the patient or not. So in 2013 and 14, new features and functions were added, and one of them were the unsigned notes, meaning that the patients in Uppsala could read the note before it was signed by the physician or the nurse that had written the note. And this was, of course, also controversial functionality. We also could see that the log lists, when they were distributed to the patient, they caused a lot of frustration by the healthcare personnel. They weren't secure in whether the patient should read this information or not. Should they understand that a lot more people from the healthcare side actually read the record or the note without being actually involved and without being the one who has met the patient at the in the hospital or at the ward. In 2014, there was the possibility to add your own note as a patient to this service. And now we have 16 out of 21 regions connected to this service, but still we have the question, what about the content? Since we have this autonomous possibility that every region could decide which information to provide to the service. Then it depends whether you live in Uppsala or in another county council, what kind of information you can read and from which date, for instance. But still, the aim is that in 2020, according to the new national regulatory framework, all citizens will have access to all information. So the strive is common in Sweden. We should provide all information to the patients. And to access this information, you need to go via the healthcare portal that is called 1177, which is also the phone number that you can call to get information from healthcare. And Åsa will later provide you with the live demo of her health record, and so you will see exactly how you do and how it works. So this talk is about 11 studies that we have made, and that INERA, which is the what can you say? Coordinator of the all national e-health services in Sweden. They asked us to sum up some of the studies that we have made that regard the patients and that regard the healthcare professionals. And we have made a number of interview studies and surveys, and we also have made some analysis of the usage data in order to see the effects on the patients and on the care professionals. And the aim of the report is to distribute what we have found so far since 2012, which could be a decision support for the deployment of the both national deployment projects and international, for instance. And we provide here an overview of the facts and the results that we have so far. So we would like to now we would like to introduce
Yes, I can't hear.
Åsa, and she will, in this role play, take the part of a healthcare professional.
Yes. Is my microphone on now? Yes. As a healthcare professional, I'm really worried that the patients can read unsigned notes before I have corrected them. I'm especially worried that they will misinterpret, that they will worry about things they don't understand, that they would interpret the situation as if they were dying, even though it doesn't really say in the text. Receiving bad news is really important. It's important that the patient has the possibility to talk to us, the physicians, so that they have the possibility to ask questions, so that they won't be worried and know what will happen. So getting bad news on a web page is not a very good idea. I also really want to have the possibility to write about suspected diagnosis. If I have a vague idea that it might be something, I would like to put that somewhere in the medical record without the patient being able to see this. Also, I think it will be very, very difficult for all patients to understand all the medical terms that are in the medical records online. We use Latin and very specific language to be efficient as a professional when we communicate.
We also have some quotes from the patient side, where the patients have in our interviews and in our free text fields of the questionnaires that we have sent out, responded to our questions, and they think that it could be the best way actually to get the bad note through the journalen. And one of the patients actually said, I would rather sit at home and cry in my sofa than sitting in front of the physician, not knowing what to say when he or she delivers that bad information to me. And they also expressed that their anxiety of not getting access to the information, to the lab results, is more concerning than the actual possibility to go and read about the what is written in the health record. Strangely enough, we can think, but they also say that it's not a problem that I don't understand the entire health record. I understand what is needed for me to understand, and what I need in order to feel satisfied about what is written about me. I don't need to understand all the exact words. And important that everyone answered. We interviewed, for instance, 15 cancer patients that had read their interviews, that had read their health records, and 15 that have chosen not to read their health records online. All of them, however, told us that they would like to have access, even though they may be not in a shape that they would like to read the information right now.
As a physician in our studies then, we could see that as a physician I'm really worried that this will increase the workload for me. I have a very stressful work situation. We got lots of patients. I don't want more work. I want to take care of the patient, not talk to them. So I think that the patients will call the hospital much more, trying to figure out what is written about me in my notes. What do these test results mean? There will also be more questions during the visits, and I'm really worried about that as a physician. I also think that this will change the way that we write the text in the medical records, and that will not be a good thing, since we need the language to be very specific and efficient. This will also increase the workload in that the patients will contact us and tell us what is wrong in the medical records, and this will take time to change these things and these small errors. And most probably patients don't understand what is important. They will call us about all minor errors that they find, and they don't see the holistic picture.
And based on these concerns, the patients reply that, well, I will not call my physician back if I don't understand everything. I will rather go to another person, some next of kin or some that I already know from the beginning that understands the medical text, and ask her or him to help me understand what is written in my health record. Possibly I could ask at the next visit, but I won't ask them in between the visits. Because I don't want to be a burden for the healthcare. We all know how stressed they are for the time being, so I don't want to be a burden for them. And I have, of course, seen that there are errors in my healthcare record, but so far they haven't been of that dignity, so it's worth changing them. The answers as we have gotten them so far.
And the physician's view and the nurse's view about the usefulness then is that this will not be useful at all for patients, because they don't understand what it is in the medical record. This is not made for them. It's not written for them, so it's of no use. And a large majority of the doctors think that this is not a very good reform. We did a survey in Uppsala, and we had around 500 responses. And 493 said that this is not a very good idea. 7 were positive. Yeah. So and it's most probably most patients will just worry when they read about the medical records. It's of no use for them.
While as the patients say, well, I would like to have this information to get myself prepared for the next visit, to be able to remember what has been said during the visit that I recently came from. And did he or she, the physician or the nurse, did they actually understand what I was telling them? So they also use the record as a memory aid and as a control function to know that their problem has been correctly understood. It could be it could provide an enhanced shared decision making, saying that me as a patient, I have my right to say what I would like us to do in the relation between the physician and the patient. It has increased the understanding of their health condition according to some of the interviews. And it has increased the sense of control for these patients. And most important is that they get the information as soon as it's written. They can read it when they come home, and they feel satisfied in having access to the information as soon as possible. In our studies, we also have results from comparisons between different professionals. And one of these comparison regards nurses and physicians. So when we look at the responses that we have gotten from several questionnaires and surveys, we see that nurses are generally more positive to the service than physicians. And we also see that the nurses with experience from the pilot county are more positive to the service compared to the people or the nurses that has not yet have access or has had patients with access to their electronic health record. Almost all of the physicians were negative in the studies, but those that were positive, when we started to doing sub-analysis of those responses, we also noted that the physicians with own experience, either as family members of a patient or as patient themselves, are more positive to the service. So a result from this could be that it's important to spread the experience of the healthcare professionals that are handling the experienced and the equipped patients, the ones that read the healthcare record. We have a number of studies that are ongoing, and we have a number of future studies in our consortium. And some of them we display up here. And one is that we will continue doing interviews with the healthcare professionals and the patients in the oncology department in Uppsala. We will also do a follow-up interview study based on the results that we have got from the 30 patients from before. We will do more analysis of the usage data and analysis of the national regulatory framework. How is it going to be deployed in the various regions, and how can they handle the national regulatory framework as it's put today in version 2. An international comparison is also an ongoing work where Norway, as one of the countries, is part of our study in common. And we will do studies with patients from different county councils to see their usage patterns and see what kind of users they are and how they use this information based on what is available for them from different county councils. And we have recently closed a national patient survey where we had, today there are 800,000 users in this service, for this service, and 2,600 answered the national patient survey. So now we are about to analyze the results and the responses from this survey. And now we come to the interesting part of the live demo. So let's cross our fingers that it works.
That technology works. So this is the start page. So I will log in. I will demo my own medical record here. You choose, here are all the services that are available in Sweden. And I will choose, everything is in Swedish because that's the standard, but I'll try to explain for those of you who don't understand Swedish. Journal services. I'll click that one. And then I'll choose, there are 2 journal services in Sweden. And the national wide one is this Journalen. So I click on that one. And then it says to me that if I have any questions regarding the information here in my medical records online, I can ask, I can look at this web page to find information. And it also says that you can ask questions here anonymously. And then I have to click. I have taken part of this information, and then I start the service. And this is my medical record then. As you can see, my name up here, Åsa Cajander. They have also all kinds of information here on the start page. If I want to look at my journal, I can look at it through clicking there. You also have notes, medicine, test results, growth curves. I hopefully don't have any. I just want to stay the same. Vaccinations, diagnosis, mother's care, motherhood's care. But I'll actually switch to my husband's medical records online because I'm quite healthy, so I don't have much to show. So this is my husband's. The other names here that you can see, those are my kids. I have 4 kids, but there are only 3 names in this list. And that is due to the fact that my 4th kid has turned 13. He's 14 now. But when you turn 13, you disappear so that the parent cannot reach that information at all. So this is my husband's medical record. If I click here, I will get an overview of everything that has happened in his medical record. And he is a cancer patient, so he's got lots of interesting and fun things to show you. Yes. Here you can see these yellow signs. This says here telephone, and there is a yellow sign here saying that this is not signed. So the medical professions have not seen this. So if I click on a visit, for example, it falls out everything that was written during this visit. This is a visit regarding he's got a problem with his jawbone as a result of this infection. Most of these words they use are quite normal. And then you can see all information from all hospitals in the area and also primary care notes. Everything is in one display here. And you can see both signed and unsigned if you want to. You can also choose not to see what is not signed. If you feel as a patient that you just want to see whatever is correct, that is okay too. We know that 98% of all patients want to see everything immediately, so this is not a feature that's very much used. I wanted to show you these lab results. They are here. We want to look at it as a graph, for example. Then I can choose what test results I want to see here. I'll just pick a few. So then you can see how these test results look like. The dates are from May 2015 until now. He had his cancer treatment in this period, and you can really see that on the test results. You can also look at his the HB value. The same here. You can see that during the treatment it was really chaotic, but it went down. I'll also show you the I think this has something to do with the kidneys. The same there. So as a patient, I can go back in time. I can decide from which date until what date I want to see it. In another view, you can also see the intervals, which are the normal variation of this kind of test, if you want to. You can also go and look at referrals. This functionality is down at the moment, but a few weeks back, it says here that you cannot see it. A few weeks back, you could see it as a timeline where the referral are. It's sent, it's received, and now you have the answer. So you could see the dates and where it was. So all the referrals are here. You can look at everything, what they say, and sometimes you also find the test results here. Here are all the medications that my husband has. As you can see, he's not very healthy. He's healthy now, but he's okay. You don't have to worry. But he's got lots of medications. If I would have shown you mine, you would have seen antibiotics, and that's it. Under this ombud and loggar, you find you can give access to your medical record to whoever you want to as a patient. So I have in my medical records, I've given Isabella access to my medical records since she has no medical records online to look at. So my husband has given me access, and he knows that I'm demoing this. But in this system, he could also see. These are medical doctors and nurses who's been into his medical record looking at it. And he can also see who's been looking at it. So you can see it's mostly me who's been in his. Yeah, so I use his a lot. He's not very interested. Here you can also block the journal if you want to. Block it completely so that no one ever can access anything from this web page. Yes, I think that was it.
So, if possible. Yeah.
Okay. Thank you.
You will switch.
No.
It's interesting. Anybody has any questions? Because I think it's an interesting thing what you do. And so, what is your user experience as a citizen?
As a
That's
citizen, I mean, as a relative. I've used the medical records online every day for a few months to understand what happened, to remember. Yeah. So first I did interviews with medical doctors, and then I did interviews with cancer patients, and then I turned into a relative myself. So I have fairly a good understanding of how it is using it as when it comes to cancer.
Because we think if we can involve the citizens, the relatives, and the patients more into the process, that can be a driver in democratization, digitalization, in the whole reform of the healthcare system. And is that what you experience?
Yeah, yes it is. Of course I understand more when I come back to the healthcare professionals. I understand more what they are talking about. And I also Google quite a lot. I know that physicians don't like that, but it's a way of understanding.
Dr. Google is important. Is anybody else who has a question? No, not yet. Thank you very much.
Thank you.
Thank you.
I have a little gift for you, but it's down there. So we continue from Sweden to Denmark, and with a more European perspective, maybe. First wait till the scene is changed. You take all your stuff with you. There, yeah. There. Okay, we get. We can come. Susie Wagner Bondorf from the company Sinsana, and she will talk about patient empowerment. Interesting. You have a lot of experience with this. So,
Yeah.
What do you think about what they show in Sweden? Is that okay?
It's very good. We have something similar in Denmark as well, and it works very, very well. And you do actually empower people by giving them information. So this is evident that it works, and it's good.
Okay, nice.
So, thank you very much for having this opportunity and coming to talk to you about patient empowerment in the context of mHealth. I am a founding partner of this international IT management consulting company called Sensana, and we are working on some new EU assessment guidelines for the Commission, and I will get back to that at the end of my speech. Before that, I will talk a little bit more philosophical about these solutions. Yes. So, many years ago, when I made the step out of nursing into computer science, people asked me if I was a little confused, because that was quite a step to step out of nursing and go into computer science. And then I found this quote from Florence Nightingale, where she says, "The purpose of data collection is not to collect casual or strange facts. Its purpose is to save lives and increase health and comfort." And she said that in 1959. So I mean, that was not a new focus I chose there. I just maybe simply have a welfare health condition which I believe I share with most of you in here. It's called technophilia. But when we use these tools, I think we should be very focused on what they mean and which purposes we are trying to support, because there might be some things to consider. We have this digital health continuum where we are at one side of the continuum where we are 100% citizens, and in the other one we are 100% patient. And somewhere down the line there is a breaking point where we talk about telemedicine. And telemedicine seems to be a magic word these days. But let's look into what it actually means. This is the tipping point. What we mean here is to provide some remote service provision, but there are many kinds of that. I took these definitions from Stanton Newman in the City University of London. He's talking about telehealth, where we have the remote exchange of data between a patient and a healthcare professional to assist in the diagnosis and management of a healthcare condition. An example could be blood pressure monitoring, blood glucose monitoring, and medication reminders. The next level could be what we call telecare, where we have remote and automatic passive monitoring of change in an individual's condition of lifestyle, including emergencies to manage the risk of an independent living. Examples here could be movement sensors, fall sensors, and bed and chair occupancy sensors. And the third one is the magic word telemedicine, and that is, from this definition, something completely different from what we normally refer to when we talk about, not different, but very specific from what we normally refer to when we say telemedicine. He says that it is a remote transmission of patient information to a clinician for an expert diagnosis and or management. And these systems could be MRIs, X-rays, and symptoms reports. So now when we are looking into mHealth, WHO are out now talking about mHealth as medical and public health service, health practice supported by mobile devices, such as mobile phones, patient monitoring devices, personal digital assistants, and other wireless devices. This could, I mean, if we just go one back, could probably fit into the first one, telehealth. And yet, we keep on referring to all of this as telemedicine. So, if we look into, take a little you can say that there are two kinds of technology appreciations out there. There's the classical one, where you're talking about technology as a tool, and then there's the other part where we can see that technology is seen as a change agent. When we have the approach of technology as a tool, we will always see it as supposed to ease life. And when it doesn't work, the technology and/or the design is to blame. I mean, you can use a hammer for some things, and if it doesn't work, it must be because of the hammer. And if you look at technology as a change agent, then we've had thousands of years where humans and technology have been developed in a mutual interaction, where body and mind have been changed. I mean, just look at my glasses. Both my body and my mind is changed due to my use of that. That's a piece of welfare technology, we all know. So in fact, we are what we could say cyborgs. The body and the technology are integrated, and it's not just a tool and a user, but we are inseparable. In the understanding of technology as a tool, in Denmark we had some years ago a huge national fund for what we called the Manpower Saving Technology Fund. It was very quickly turned into what we call the Robot Vacuum Cleaner Fund. And they never get to spend all their money, because just placing technology with elderly people where they don't know how to, they're afraid of it, they don't know how to maintain it, and it's a little scary, so they never get to use all that money. But all the politicians, they saw this as a very strong tool. Now, instead of sending out all these public service people, we can simply provide all elderly people with a robot vacuum cleaner. That's a funny traditional view of use of technology. Yeah. Then technology as a tool, it doesn't always work like we want it to. And then we blame the technology. Maybe we should have looked into the implementation instead. But then we look at technology as a change agent. It does something to our body and to our mind. This is an exercise trainer. You get something, you get into, you exercise your muscles, and you exercise your brain, and you are having fun. So that's another way of looking at and using technology. Yeah. We adapt very fast to technology, especially now. This is a picture I took from Facebook. My children were making such fun of me, and I didn't understand why. They were having such a laugh, and I was staring at this picture and saying, what is funny? I mean, I simply didn't understand what is funny. And I saw the headline saying, Mom texting. And you know what she's doing? She's sitting here with her mobile phone, texting like this. And they thought that was so funny, because when they text, they do like this. And I realized, even within my own family, in our own generation, things happen so fast. And then I got to think about my mother-in-law, when she first had her first mobile phone, and we taught her you need to press the green button, and then once she's completed talking, she just put it on the table. So we adapt so easily to new technologies, but in our own way and at the competence level where we are, due to when we were born, literally. Okay, let's see. So in the technology as a tool appreciation, we are selling technology, we are selling visions, and we are selling progress. And we are promising to fix everything. In technology as a change agent, we are creating both. We know that we are creating both solutions and problems because there is no such thing as a perfect technology. We are realistic in upsides and downsides. Well, we need to be. Sometimes we're not. And when we have the technology as a tool perspective, we will see that, and we will monitor everything that can be monitored. But do we see some things in the expense of something else? I believe we do. We had in Denmark a huge wound care program, and we saw suddenly that due to simple, well, not always simple, but simple wounds, people and the mortality rate started increasing. Why? Very, very strange. Why did people die just because we photographed their wounds? And the simple answer is that we forgot the whole picture. We only saw the wound. We didn't see how is this person living and feeling and reacting to other conditions that we normally do. So technology is not the answer to everything. We need to have the entire picture. Okay. So, mHealth give us better and more health. Let's hope so. But it also gives us false positives and false negatives. Not only clarity and safety, but also new questions and insecurity. Hyper-calculating individuals having to relate to probabilities and scenarios for their health development. I mean, we are turned into neurotic hypochondriacs. It could be. People are constantly working to avoid health conditions. Health services are stressed, not eased. And some will be healthier, but who will fall through? You know, we are talking about health literacy, and it's again the survival of the fittest here. So, mHealth will bring solutions with new limits between body and mind. Between the body as an object we control and as something we are assigned to, a distance between me and my body. New divisions of responsibilities between health services and citizens, an increasing degree of responsibility for own health and new ways of perceiving and make laws on the individual's role. I take the liberty of bringing some Danish into my speak because I know that the Scandinavians in the audience will understand. Because in nursing, we refer to self-care as egenomsorg. And very often, patient empowerment is mistranslated into egenomsorg, self-care. And then in Danish we'll say, pas dig selv. And that's take care of yourself, and meaning go away. And this is something that we will not want our politicians to put into law. We don't want them to force people to have a robot vacuum cleaner. We don't want them to have an app just to fix things. We've seen mortality rates going up for wounds. We need to be very aware how we affect this. There are no such thing as a quick fix in this. We need to be so cautious in how we adopt this. Yeah. So this might result in better health for some, but at the expense of acceptance of death. That's a true condition in life, that we are going to die. And the fact that life is full of surprises, and there's something is bigger in us sometime. Yeah. So now what? When we choose a relevant app, we need to look into other than market tests and or certifications. Both technology appreciation must be considered when developing apps. So there are differences in technologies and how well developers are capable of double perspective. I don't know, sometimes I switch between a MacBook and a Windows PC. And operating a mouse is horrible because your brain is so used to whatever environment you came from. But in fact, and Apple should pay me to say this, they do actually have that double perspective because you can go in and set the settings to whatever scrolling perception you prefer. But I mean, we need more of that kind of thinking. So we need an increased focus in the role of the technology, and it may result in more innovative solutions and maybe completely new ways of seeing a problem. The double perspective might be a very rich source of radical innovation. Yeah. Okay, returning to practice. This is not rocket science, but it's gives a little perspective. So in Denmark we have 27 hospitals on 70 addresses, and we have 2,100 GP clinics. That gives us 150,000 conceivable information exchange ports. If we, on top of that, put our 98 municipalities, then we will have 14 million conceivable information exchange ports. And then we have 50 million patient contacts with 5 million bed days. And then we want the patients to understand it all. If we take this complexity up one step, with all the new data sources from the apps, we are facing a tsunami here. So as a healthcare professional, you will ask two things, I guess. One is, how can I choose from all these solutions? And how do we make sure the data is both valid and reliable? And now I get to the work I do for the Commission right now. This is work in process, so I cannot tell you any details, but I can tell you about the process. And early next year, 2017, there will be launched some things about this. So the official title of what we do is called EU Guidelines on Assessment of the Reliability of Mobile Health Applications. We've turned that into better use of better apps for better healthcare. There are now, normally we see only that there are the CE marked apps, and then there is all the rest. Now we are taking, we have them here, we're taking and adding another layer in here where we have the other apps used in a medical setting. And to give you one example, you know, we are all running around with these bracelets, counting our steps. They also make some monitoring of our sleeping patterns. And those data could, in fact, be used as a clinical decision tool in diagnosing people with depression. So the key word here from the medical device directive is whether it's intended use or not. So there are so many apps and so many devices out there where the intended use was not clinical decision making, but they have in fact very good data. So we want to include them, and we want to make some sort of assessment tool whether to use them or not. So it has, of course, to do with data reliability, data validity, and of course, comparison between different solutions. So if I come with my Jawbone bracelet, and you come with your Sony bracelet, and someone else come with the one from Samsung, they need to be comparable. And that makes it completely complex. So the process is that we are we have 35 specialists in the working group. This is a 4-iteration process with public hearings. You can find it on the Commission's internet. If you Google mHealth assessment guidelines, you'll see what we've done so far, and you will also have an invitation to send us your comments. Then we have stakeholder consultation, and the final draft will be submitted to the European Commission early next year. Yeah. The outcome. We are still in process of finding out what the product, what form the guidelines will have. But we will probably, we will probably be using a decision tree like this. This is from Catalonia in Spain, and this is one of the examples, and this is probably what we are aiming at. So we are not planning to come out with such a huge report. We want to give you tools to do this and to be very quickly and easily turned into decisions. Yeah, I guess that's it. Thanks.
Thank you. That's interesting. I mean, this is another part of what we talk about, of gathering all the data and what you do both as health professionals but also as patients, as citizens, because you have to need to understand all those data. I mean, how much I walk a day, I can understand, but if you start to measure different kind of things, that's quite more complicated.
Yes.
So, is there anybody else who has a question? No, it looks like not. Okay, thank you.
Okay, thanks.
Then we are a little bit before schedule. There is a final session with the in the main stage at the 4:10 with the Medical Association, Legenverenigingen, and Nurses Organization. It's not very long. I think it's 2 times 10 minutes they will talk. I hope you have an opportunity to stay for the last final session over there. We're finished here, so take a cup of coffee and thank you.